Good afternoon, good morning if you're on the West Coast. My name is Hallie Fader Tao. I'm the Director of Justice and Health Initiatives at the Council of State Governments Justice Center. And we're so happy to have you here on the anniversary of 988's national launch for the Aligning Health and Safety State Innovations in Crisis Response. Today is the fourth anniversary of when 988 was launched nationally. And in honor of the anniversary, the National Alliance on Mental Illness and Ipsos poll released today findings on public support, understanding, knowledge of 988. In the results they released today, 30% of adults reported experiencing a mental health crisis. Just sit with that for a second, thinking about almost a third of the adults in our country experiencing the urgency of a mental health crisis. Another interesting finding from the poll that I think speaks to today's webinar topic is that 87% of those surveyed supported both state and federal funding for 988 and crisis response services. So in a moment where many states and the federal government is looking to be as responsible as possible with funding, the population overwhelmingly 87% is supportive of federal and state funding for a mental health suicide prevention crisis line, as well as advancing and enhancing crisis response services. At the Council of State Governments Justice Center, we have been really proud to work with Pew Charitable Trusts over the last 2 years on the Aligning Health and Safety State Crisis Responses Initiative. Our goal is to help states get the right response for each crisis. Today, we will be sharing experiences from 4 very different states: New Jersey, Virginia, Utah, and Washington, as well as a brand new tool that we'll be launching today, focused on what states can do to make sure that each crisis gets the right response. Before we go further, though, I'd really like to welcome Connie Utada, Senior Manager at Pew, to talk a little bit about Pew's interest in this work and looking forward at mental health and justice from here. Thanks, Connie.
Thanks so much, Hallie. And I want to take up as little time as possible, just so we have as much time for the states as we can. But also, I want to thank everybody for being here. Good morning, good afternoon. And especially the participating states. Really want to thank you for your leadership and commitment. And as you know, it takes courage, energy, and time. Oftentimes, we're in short supply of that. And we're grateful for your partnership. I also want to thank Hallie and the CSG team for their leadership and facilitation and support of those states. Just to give a little background about Pew's work in the behavioral health space, since 2020, Pew's Mental Health and Justice Partnerships Project has conducted research and worked with local, state, and federal stakeholders and policymakers to examine behavioral health and crisis care across the country. The project supported research and policymakers in creating robust systems of crisis care that meet people where they are, and to try and ensure that anyone with a behavioral health need can access effective care no matter where they are or who they are and who they call. It's with that goal in mind that we've partnered with the Council for State Governments Aligning Health and Safety Initiative. Another note about Pew is that our current project, Mental Health and Justice, will sunset at the end of this year. And the work that is ongoing will inform kind of potential future work that Pew efforts that we get involved in. In terms of the behavioral health space, Pew has also ongoing projects that are working to improve physical health outcomes, especially looking at data in healthcare systems, reducing suicide risk, and then preventing and treating substance use disorders. So those are current and ongoing projects that are continuing at Pew. We're also exploring a couple new areas within the behavioral health field, including challenges related to youth mental health, the 911 system, and the behavioral health workforce. So if any of those ongoing projects are interesting, I'm happy to make connections for folks. Just to kind of more in conclusion, the Aligning Health and Safety Initiative was designed to support states, as Hallie mentioned, to develop a clear statewide vision for crisis care, one that reflects each state's unique needs, resources, and communities. And just in reflection in this process and this other work that we've done with other states, we understand that government system change, these all show incredible challenges in terms of implementation and coordination. This is not new and not easy, probably for many of you who are on this call. If it were, every state would have solved this problem already. But what we've seen, and I think that maybe a lot of states and localities are starting to see, are that developing these innovative, practical approaches, some of the persistent challenges in behavioral health crisis is really bubbling up. People are really kind of rising to the occasion. And while every state is unique, a common theme is that in order to implement and to create effective crisis care systems, it can't happen through any one sector alone, right? They require ongoing coordination and shared responsibility across a number of partners, and that includes behavioral health providers, community response, the justice system, law enforcement, Medicaid partners, which obviously is incredibly challenging and takes a lot of time. And when you hear from the states, many of you will likely recognize similar issues in your own. We hope that the experiences and insight from New Jersey, Utah, Virginia, and Washington really offer useful lessons and spark new ideas for how you might address similar issues in your communities. I'd also encourage each of you to explore the Aligning Health and Safety Initiative's new tool. I don't know if that's probably going to be a link that's on the chat at some point. If you haven't already, it really offers a lot of practical resources and real-world state examples to help improve crisis response systems. So with that, I'll turn it back to you, Hallie.
Connie, thank you so much. It is hard to imagine in the work that we do something more intimate than crisis, right? It is somebody's worst moment, somebody observing someone else's worst moment, and the response is so direct, whether it's the person who is talking to the person in crisis, somebody who is responding, de-escalating a situation, or bringing somebody to care or a secure setting. And one of the questions we've gotten as we've talked about aligning health and safety crisis as a state policy approach is, well, what's the role of states in that? If it's so profoundly local, how phone calls are routed, how dispatch happens, who shows up, what is the right role for a state to play in ensuring crisis response? And this question of the interplay between state policy and local response is really at the heart of the Aligning Health and Safety Initiative, whether it's crisis response or another area. As we have been rolling this out, we've been trying to elevate the places where state leaders across the three branches have unique opportunities, whether it's through legislation, regulation, funding, coordination, just the championship, elevation of an issue, where states can play a role in positioning localities to have the right response to crisis, or even getting out of the way of localities as they try to get the right response to crisis. Doing that well often requires crossing agencies or departments. It could even require crossing branches of government. It requires learning from very different local experiences. You'll hear from our states today that what works for Salt Lake City or Newark is not going to work for rural parts of those states. So as state policymakers, they need to be understanding what's happening locally and crafting state policy responses that are flexible enough to be useful and responsive to different local needs. In selecting these 4 states, we were looking for states where there was committed state leadership to making a change in some aspect of their crisis response, as well as a commitment to working with local leaders and community members to understand what's working on the ground, where there are challenges, and to partner between state and locality to bubble up or surface strategies. Again, could be legislation, could be training changes that would improve some aspect of their crisis response. I think as you listen today, you're going to hear about some states that started with a strong statewide vision, that and then double clicked into a detailed area for implementation, and other states that started with some really robust local implementation and realized there was an opportunity for more statewide strategic planning. So it has been really exciting and I think telling about our 50 states that they're going about this in different ways, and there is a lot that they can learn from each other. Last fall, our 4 participating states, our partners at Pew and NYU's Marin Institute, got together to talk about where are there real opportunities, state policy levers that can be deployed to improve local responses to crisis. And through those conversations, we ended up with 5, 6 areas. I'm going to ask Greg to pull up a poll as I mention these, and would love to have each of our participants vote on which of these is the biggest priority in your state. So these 6 areas are establishing a strong foundation for long-term sustainability. And in this first choice, we're really talking about committed leadership. Is there somebody who is at the state level who is making improving crisis response a top level issue each day? Second was around data-driven crisis response. We know how many different data systems are involved in trying to piece together what's happening through 988, through 911, as well as across a state. And the participating states really talked about some of the data collection, sharing, analysis challenges. The third, no surprise, had to do with funding. How are states using federal funding, state funding, local funding to braid together a system to pay for crisis call response, someplace for people to go? Fourth was from the state level, being able to foster responses in diverse communities, whether it is the difference between what happens in a major metro area or in a very rural area, whether it has to do with reaching different types of communities, different languages, different relationships with law enforcement. How at the state level are you planning for the diversity that exists within your state? Number 5, integrating 988 and 911, being able to raise awareness of 988 as an option and creating interoperability, both from a human perspective as well as from a technology perspective. And finally, as Connie mentioned, expanding the workforce. We have really new generations of crisis responders out there, whether community response, violence interrupters, community health workers, co-responders, mobile crisis. There is a whole new emergent field that is seeking out a professional identity, defining their professional identity, and what can states do to ensure that they have people in position to take the call, to respond to the call. All right, I hope I gave everyone enough time to read those responses and click in. Greg, do we have enough folks who have voted to show some results?
Yep, we're over 50%. I'm gonna go ahead and end the poll at 61%. And now we're sharing the results.
Great, thank you. We wanted to do this. I think it's interesting and sort of validating that it's pretty similar responses across the 6 categories. It looks like we've identified areas that are all of interest. Again, not surprising to see funding being one of the top priority, but we wanted to do this particularly before we introduce the panel so that as the panelists are talking about what they're doing in their states, they're able to hit on some of the priorities that the audience has identified. So starting with funding, also the importance of diversity within a jurisdiction, leadership, workforce, data, and 988 911 integration. So that's a little bit about our project. I'm going to turn it over to my colleague, Ernie Stevens, to facilitate a conversation with representatives from our 4 states. And then I'll come back at the end to share the tool that Connie mentioned that came out of the conversations among the states, as well as the work that we've done with these states and others around the country. With that, I'll turn it over to you, Ernie.
Thank you, Miss Sally. I appreciate it. Well, I get the honor to introduce our panel. I hope that you are truly ready to be engaged with some rich conversation. And as I introduce this panel, they truly are an all-star panel. I kind of want to change my voice to be like an NBA announcer as I call out their titles, but I will not do that right now. In no particular order, let me introduce Miss Tiffany Wilson, who is the Director of Office of Alternative and Community Responses, New Jersey's Office of the Attorney General. Our second panelist is Ms. Leanne Huff, who is the Program Administrator of Crisis and Mobile Crisis Outreach Team Services in Utah. She's with the Department of Health and Human Services. We have Mr. Kurt Gleason, who is the Assistant Commissioner for Crisis Services, Virginia Department of Behavioral Health and Developmental Services, and Ms. Kimberly Hendrickson, who is a Program Manager with Washington Behavioral Health Crisis Outreach, Response, and Education. I don't think any of that's going to fit on a business card, so I am so glad that y'all are here to join us today. And I've got some questions. I want to ask some questions, and I want to make sure that we save enough time at the end of this presentation to get some Q&A from all of our attendees as well. So again, in no particular order other than alphabetical order, we will start with the state of New Jersey. Again, that is Tiffany Wilson, who is here, who is the Director of Office of Alternative Community Response with the New Jersey Office of Attorney General. Hello, Tiffany. How you doing?
Hey, Ernie, how are you?
Fantastic. Thank you. All right. Are you ready? Hot seat.
Sure, let's
There
go.
you go. Fire away. Well, we know that New Jersey's been working to build a more coordinated crisis response system across not only 911, but 988, behavioral health, law enforcement, EMS, and community-based services. You've tried to encompass all that. But I got to ask, like, how'd you get there, and what still needs to be done? And I want to add on to that, what has the state really defined a shared vision to ensure that each of these behavioral health crises truly get the right response?
So the how we got there, in some ways, I would love to say we did it very purposefully and we are brilliant. That did not necessarily happen. I think we were really doing this work in silos, and I think one of the things that we've all realized is the silo doesn't work. But we all recognized a problem. So when I say we all, the public safety aspect of it, so law enforcement was seeing increases of uses of force when a person was in a mental health crisis or maybe on the verge of a mental health crisis or at risk for a mental health crisis. Our healthcare partners were seeing maybe overuse of, in New Jersey, we have screening centers, so our crisis response center for people that didn't meet criteria and then were getting released back, which was causing frustration for law enforcement. So we were breaking a lot of relationships there. But then they were also seeing underuse in some communities because there was a lack of trust with the healthcare system. And our community partners were saying, we just think this is broken. We're seeing members of our community, unfortunately, dying during a mental health crisis. And unfortunately, also for law enforcement, was at the hands of law enforcement and all of the things that occurs to sort of break that relationship. And so I think all of those entities were working separately to try to solve this issue. So from the Department of Law and Public Safety, or the Attorney General's office, we started a program that provided a mental health resource to law enforcement officers when they were responding to these situations, like to the crisis situation, which then very quickly became, wait, can we just avoid the crisis altogether? So can we give law enforcement a resource that helps them avoid the crisis? And that resource was a human resource in the form of a mental health professional. And we were really lucky to partner with the Department of Human Services, or DHS, here in New Jersey, to use their existing system but provide law enforcement specific partners, so that they had a partner to do that work. And so we call that the Arrive Together program. At the same time, Hallie mentioned the 988 anniversary. So our 988 team, run by DHS, was looking at all of the pillars of 988, and they were creating their response pillar. So we call that M-Courts here in New Jersey. So they had when a 988 call leads to a situation where there needs to be a response, M-Courts can respond with peers to assist an individual in that situation. But our community partners were also very actively and very deftly advocating for there has to be another solution. They were doing really great community-based violence intervention work in a lot of our larger cities. They were creating and growing a network of trusted messengers in those locations. And they were hearing from their community members, like, why can't you help me with navigating this system I don't trust? And so they, again, very deftly advocated for legislation that would allow for community crisis response teams, or what we would call CCRTs, because we live in the world of acronyms. And we were all doing this separately. In particular, our community-based groups were advocating for a law to sort of create these CCRTs that was going nowhere in our legislature. And then, unfortunately, there was the death of 2 of our citizens here in New Jersey during a mental health crisis that brought it back to everybody's radar. And so it finally passed as the Seabrooks-Washington Act here in New Jersey that created pilots of community crisis response teams. But at the same time, we here at the Department of Law and Public Safety were creating the Arrive Together program, and DHS was creating M-Courts. And so the version of the law that got passed was very similar to the original version and didn't take into account the landscape. And so we had to do something about that. And one of the things that the legislation did was create a council that was tasked with providing recommendations. And luckily for us, CSG came along at the right time. And we said, can you help us with this? Can you help us with what these recommendations are, but also help us to educate each other about the roles that we can all play in this and what already exists? Because I think there was a real misunderstanding of what already existed in the state. Can you help us with all of that and help us to continue to open those lines of communication, that understanding, and then come up with some recommendations that might help us all to get to what really was like a common goal. We were just coming at it from different places, and we weren't really in the habit of talking to each other about it. So it's sort of how we ended up getting here, was because we needed to get here. And we have really done it. Yes, there is legislation, but we have really done it through communication and collaboration, and really opening our minds up to better understanding everybody's point of view and the strengths that we bring. And in no way saying it is perfect, it is not, but we are definitely on the path towards that.
Well, you said a lot there, and I'll say this about New Jersey, and for the attendees that don't know, when I went to New Jersey a few years ago to speak, and I got to see not only the Arrive Together model, but your entire state has a CIT associate. I mean, so it's the training is truly a priority of the state when it comes to crisis intervention training. So when you have these models that are working together to respond to community members in crisis, you have these better outcomes to avoid these tragedies. But you brought up the Seabrooks Washington legislation. So let me ask you a question about that. So passing the Seabrooks Washington legislation, you said it established funding for community crisis response teams and the Community Crisis Response Advisory Council. So that's an important milestone. But let me ask you this. What challenges do you feel emerged in translating statewide legislation or policy goals into practice at the local level?
So I think one of the challenges, and I'm guessing that many people on here have had the same experience, it's the difference between something that's actually a law and something that's a pilot, and everybody understanding that that's what it is. So one of the challenges that we had was, again, we had really strong advocates who really wanted this to happen. But what the law said was, we're going to create these pilots. And so one of the issues is, did we accidentally create a situation where people had expectations that may not happen or come to fruition because it's a pilot? And it caused some tension in that there was sort of this expectation, I think, of a lot of the advocates and the public in general, because there was a lot milestone law. So I think there was a feeling that there are going to be these CCRTs. It's going to happen. It's going to happen immediately. And that just because we passed a law, it's going to be, and they're going to exist, and they're going to be part of the infrastructure. And that wasn't what it was. So we sort of had to everybody get back on the page of, okay, can we get to a common base of what this is? But what it did was it opened the lines of communication. It brought us to a better place of understanding, and hopefully to a place where we're going to be able to suggest something that really integrates to the whole of what is happening in New Jersey. So the positive was, it put it on the radar. It said, this is a priority. This is a legislative priority. We want you to be thinking about it. We want you to be doing it. I think the negative was, in some ways, it created some tensions in a place that really only thrives when we're all working in the same direction. So we had to sort of walk that back. I think the other thing it did, again, led by advocates who have been burned before, and so know that the system is not always in their favor, that the granting system in the state, I'm assuming New Jersey is not unique, takes forever. The procurement rules in the state, how long it takes to get a grant out the door and the money out the door, and that it doesn't come in a big chunk of money, but there are rules and federal rules and local rules around that. They tried to address that in the legislation, and in doing so, in some ways, it made the legislation more prescriptive than they really wanted it to be. And as the grantor, because the Department of Law and Public Safety was handed the grant, we had to enforce those rules while we were seeing our grantees saying, but we can do so much more. Like, we're in our community. We know what our community wants. We can do so much more. And unfortunately, the legislation didn't let us do that. And so, again, in a really great way, it's put it on the radar. It's opened the conversation. It's helped us to broaden the CBVI work that was happening. It's helped us to broaden our understanding of how community can really be a key part of the crisis response. But it also, in some ways, made it harder because some of the great ways everybody recognized weren't allowed by the statute. And so we've had to sort of navigate that a little bit. So that's made it hard. But it also put funding on the table, so that's never a bad thing for organizations that were coming up from the community. So we'll take it, but hopefully a next iteration of whatever it is allows for some flexibility. And that was really one of the things we learned from the Arrive Together program. Is it was originally straight co-response, and we very quickly realized that doesn't work for every community. It's not the need in every community. Can we be more flexible? We were able to do that with our funding, but that isn't prescribed in the current pilot.
Okay. Well, as we get Utah to get ready to come on deck, let me double click real quick on, you mentioned coordination. So last question for you.
Yeah.
Looking ahead, how is New Jersey advancing community crisis response efforts and coordinating that coordination effort across agencies and partners to provide effective response to crisis calls?
I think we're really grateful that the state gave us this opportunity, or I don't know, handed us and said, please go talk to each other. But I also think that we were getting there anyway. And so I think one of the things that we have really done that I've been in public service for 28 years. I think this is not something we have always done, but I think we're starting to do it. We are talking to each other regularly. We are prioritizing understanding what our lanes are, what our roles are, but what each other's jobs are and how we can help each other. And I think anybody who does this work knows like it's relational. It's about relationships. And we are building an infrastructure that is about relationships and about understanding how we can help each other. And the state, luckily, has both funded and set forth the common goal. We know that the state recognizes there is a problem, and we have been very lucky that the state has funded it. And I think it's now us, the agencies and our community partners' job to work together to get there in a way that serves our citizens and our communities.
All right. Well, thank you, Tiffany. I appreciate your time. I know that we'll be back to you because I see a question in the chat already for you. So we'll get to that at the end, and we will welcome up next Miss Leanne Huff, again, who is a program administrator of crisis and mobile crisis services in Utah with the Department of Human and Health Services. Hello, Leanne. How you doing?
Good. Thank you. Hello, Ernie.
Yeah, I'm glad you joined us today. I want to talk about your work specifically, and of course, I got a grin on my face because I got to work with Utah specifically on this project. So I would love for you to share, that Utah's work centers on mobile crisis outreach teams, and you oversee this. So what was the biggest systems or policy challenges to scaling MCOT statewide? Because, I mean, Utah's got some very rural areas.
Yeah, we do have some rural areas, and I would say our biggest challenge was the workforce shortage when we scaled statewide. We were for the 24/7, and it is because the rural areas do have a lot more challenges with hiring for these teams. So in Utah, we have a standalone response model that acts as the primary responder for mental health. And we will utilize law enforcement if it becomes a safety issue, but we definitely, on a statewide level, we promote MCOT as a standalone response, which would be a two-person model, a clinician and a peer support preferably, or case manager 24/7. So that challenge was in the rural areas of finding, a clinician to work that 24/7 role in those areas, and even in the urban areas as we built out so quickly. One of our successes when we were building out a statewide program was that we were very fortunate and had a lot of support from our legislature. This was really due to the bipartisan effort in suicide prevention, as well as the recognition, as Tiffany said, is that law enforcement has been that de facto response to mental health for a long time. So those two together really, the legislature bought into how do we change that. And so in 2018, we had two important bills pass. Senate Bill 31 and House Bill 41 that established funding and standardization and guidelines for a statewide crisis line, as well as expanding mobile crisis teams across the Wasatch Front. And so that, and then in subsequent years, we were able to fund the whole state.
So what's interesting about Utah, and I don't know if many of the attendees know this, and I'm not sure if this is what contributed to the workforce issue, but in Utah, MCOT can be dispatched through 988 calls.
Yes.
And we've seen just the influx of 988 calls. It just every year there's more and more of them. I mean, do you feel like that contributed to part of the workforce issue?
Yeah, the expansion of the growth and the demand for those smaller areas to respond. Yes, because 988. So as Ernie said, in addition to that standalone model, the goal is ER diversion and law enforcement diversion, and we created a hub and spoke model where our statewide crisis line can dispatch to all areas of the state.
Well, thank you, Leanne.
Yeah.
Next question, because this is interesting when we talk about your data dashboard, because I think you really have a very robust one. But what is Utah learning from its data dashboard work about crisis response statewide?
Yeah, so now we have created public-facing dashboards, which you can look at the state as the whole, or you can filter it into region. And we work monthly. We meet monthly with our local mental health authorities to go over the data, look at what's working, maybe look at outliers. And what we're seeing is that the crisis now model works brilliantly as designed in the urban areas. We hit all the indicators in as far as MCOT stabilizing 70%, the crisis line resolving 85 to 90%. All those indicators hit the marks, but in the rural areas, we're just seeing some differences that maybe the indicators are a little different for rural areas. Speaking to Hallie, talking about those individual differences in different regions of the state. So as we're looking at that data now to get a better understanding, and how do we retool what works the best there, and to collect indicators accordingly.
Okay.
To really obviously the outcome is to give the right response, the best response and the best quality of care. So how do we look at that differently for the rural areas?
Yeah, and I looked when in fact, I was just in Utah with you a few days ago, it seems like, and I looked at strategically the geographical locations of your crisis stabilization centers. And I was particularly impressed that, that the rural areas were not disregarded when it came to providing crisis services in that area. And I thought, that says a lot, when you have to put in a lot of dollars into that kind of infrastructure, to ensure that people in those communities get the help that they need. Utah didn't spare any expense on that. They really went all in on crisis response.
And so we do have we have several rural areas that now have receiving centers. One's up and running, and we've gotten really good data from. The other ones are still in the process of getting the dashboard going and getting up and running. But yes, you're right. We definitely were able to get that support financially to support the three pillars.
Yeah, very impressive. Next question, because I could go on with you forever on this. What role did cross-agency coordination, like behavioral health, EMS, law enforcement, what did that play in getting MCOT where it is today?
Huge. As Tiffany was saying, those relationships are incredibly important. And for us in Utah, it really started in Salt Lake County in 2012. Not only was there the community desire, but we have a very strong CIT program here. And in 2012, our CIT program was really partnering with Salt Lake Behavioral Health Services to promote bringing in mobile crisis and a receiving center, really modeling off Washington State. I think a group of stakeholders had toured to Washington State, and so there was a lot of advocating. And so we were able to bring in those services to Salt Lake County back in 2012, which I think really helped facilitate the statewide expansion later, because we already had all that rich data to support that going statewide.
Got it.
But
Well,
yeah, the stakeholders are huge. We had law enforcement with CIT, the hospital association, and just a lot of people supporting the build out of the crisis response system.
All right. Yep. Thank you. So as we get ready to bring Virginia up on deck, I got to ask you, Leanne, so what comes next for Utah's crisis system? Like, where do you go from here?
So now we're looking at, we have all our mobile teams out there, but we're seeing, of course, it's workforce shortage. So we're constantly trying to address that so we can build out even more teams and provide more services. And then ongoing funding. We're lucky with funding right now, but we want to make sure that continues as ongoing, and even look at private insurance as a payer for MCOT, because we do have a really good Medicaid bundled rate, but we don't have private insurance paying for the mobile crisis services yet. But we now are focusing on post-crisis follow-up. We know we're getting great numbers from the dashboard, but we don't know. We're taking a deeper dive into that quality of care, what's happening after that response. And we really want to be able to provide that post-care to be that bridger and connect people to care and make sure that they're getting that connection. So that is one of our next steps and recommendations that we have made to our for funding.
Yeah, no, that's fantastic. I've seen firsthand how continuity of care through case management can help people from cycling through the criminal justice system or the acute healthcare system. So I'm glad that's your vision. I'm glad that's where you're going next. So thank you for your time today, Ms. Leanne, and stick around. There's questions for you in the chat. All right. This is going to be a good segue here. My good friend, Kurt Gleason, we're going to go to Virginia. Again, Assistant Commissioner for Crisis Services, Virginia Department of Behavioral Health and Developmental Services. Hello, Kurt. How you doing, buddy?
I'm good. How are you, Ernie?
I'm doing good, my friend. All right, you ready? Hot
Sure.
seat. Question
Yep.
number one. As Assistant Commissioner, overseeing crisis services statewide, what was the core issues Virginia has sought to address, and how many different levers, however you want to say it, were you working with at once, from legislation to federal compliance drivers to funding?
Yeah, thanks. And also thanks, Ernie, Hallie, everyone at CSG, and Connie and Pew. This has been really a great journey with you all for the last year and some months. So I'm grateful then to be here to talk to others. And I think our story in Virginia is pretty similar to what we've heard already from Jersey and Utah, and what we hear from Washington, and probably what everyone else has experienced. But things got critical. The law enforcement was being overburdened. Our hospitals were becoming overcrowded, not to the normal degree, but to an exceptional degree. Our state hospitals and our private hospitals. It's leading to people boarding in emergency departments, and then have some unfortunate, tragic, seminal events that happened. That all of these things together, I think, highlighted vulnerabilities, risks to the systems, or maybe most importantly, limitations to our crisis system, right? We weren't able to serve people well. And before putting on my suit, I was a direct service provider. That's where I think many people on the panel. And just to be transparent and frank with everybody on the call, one of the reasons I left is that it was difficult to continue working in an environment where I couldn't serve people the way I knew they deserved to be served. And I needed a change. Fortunately, I came to a change where hopefully I can help increase the resources and opportunities. And to me, it's a paradigm shift that I think all of us that have done the work or have been around the work have known needs to happen. But those sort of confluence of problems led to maybe a confluence of initiatives, efforts, requirements that all kind of came together. We had I won't get the date, so this isn't being recorded, right? But there was a law called Step Virginia. That was Virginia's first effort to reform our community behavioral health system, to move our community services boards closer to CCBHC. Had a big crisis component. Our state is at the end of a very long Department of Justice settlement to improve our services for individuals with intellectual and developmental disabilities. A big component of that is crisis intervention. There was a tragic death of a gentleman named Marcus David Peters in Richmond over a decade ago. That led to really important legislation, Marcus Alert legislation, that requires a lot of things, of training of law enforcement, but also integrating 911, 988, developing co-response teams, and engaging local communities in developing plans to improve our crisis intervention in most acute situations. And all of that sort of comes right at the time that SAMHSA publishes Crisis Now and Best Practice Model, and all of these things come together. So I think where I'll sort of end the answer is what's been most important for, I think, the people I get to work with now and our leadership at the Department of Behavioral Health and Developmental Services is making sure that we stay vision and mission focused, right? And don't just solve this problem and solve that problem and meet this budget item and meet this legislative item, but continue to sort of pull all of those things together towards developing the better system for serve people in crisis. Our hospitals, again, I mentioned that as one, are overcrowded. And often I'll get asked some version of, well, now that you have stabilization units, why are the hospitals still crowded? And I'll say, I don't want hospitals to be crowded, but I want stabilization units because it's the right way to serve people in crisis. I don't want them to solve that problem. I want them because it's better for the individual. And then hopefully it has a downstream effect, right? So it's important to say that we have all these efforts and we're going to harness them so that we can move through the difficult work of shifting the paradigm to a better service system.
Yeah, I mean, just look at it, right? If your hospitals are crowded, usually your crisis stabilization centers are crowded because if they're on diversion, you're going to end up at a hospital.
Right.
If the hospitals are crowded, your jails are crowded because, right, the officer needs to go somewhere. And if all those are crowded, then your state hospitals are crowded because that's going to be your backstop. So I think, you've gone deep with your knowledge in this, and you've recognized that, these are the issues that need to be addressed. And you mentioned the crisis now. So I want to go back to that. I want to touch on that for a second, because Virginia has been building a statewide infrastructure of the full crisis now best practice, right, continuum. So how did you align a mixed provider landscape? Because it's difficult, right, when you look at all the different providers there. But how did you align that around a shared framework?
Yeah, we do. And I mean, just to highlight some of the sort of the diversity of providers. I don't know if that's quite the right language. We've already talked about, Leanne mentioned rural and urban, which we have too. We don't have quite the rural that Utah has, right? But Virginia has a lot of hills and valleys and rivers and bays and people live all across the state. So you got to figure out, how do we get providers and engage providers in different environments? How do we have some legacy crisis services. We have new crisis services. How do we make sure that they're following a similar model? We have our system engages both our publicly funded community services boards, but also private providers who are providing fee for service and very different models and densities. So how do we ensure that we get all of these different provider types and locations on the same board? I was about to say the same page, but I actually think that's part of the answer. We're not trying to get them on the same page, right? There's going to be a diversity of how providers build their business, how they engage with consumers, how they document the work that they're doing. And so I think it often, for me anyway, comes down to infrastructure, right? Can we create the infrastructure, the technological infrastructure, the regulatory definitions that create infrastructure, the relationship infrastructure between local providers and regional hubs and state entities and my licensing partners down the hall, my Medicaid partners across the street? Can we create infrastructure across these different entities that then allow the providers to work and do the work, right? So I don't want to not pay attention to service delivery or QA/QI. Those are obviously critical components to ensuring a healthy system. But I put as much energy into thinking about systems and infrastructure so that the pieces and parts have the playing board, right? If that makes sense. And so that, to go back to crisis now, that's often sort of the anchor, right? Are we establishing a system that facilitates that best practice model?
Okay, thank you. And I'm just going to give Washington, get ready to head up on deck. I'm going to ask you, Kurt, one more question here. So, some of this has been sustained across budget cycles already, right? What would you say, what does it take to keep the kind of support alive? And truly, where does Virginia go from here?
Yeah. Well, I think it was Leanne that mentioned, or somebody mentioned, but it's a bipartisan effort. That poll at the beginning, I kind of chuckled because when it came back and everything was like 18%, right? Because these are all big, hard issues, and they're all really diverse issues. I think it's kind of affirming that all of us are still trudging along the shift of the paradigm despite having sort of what feels like an impossible task. But that also means that, like, Virginia is a purple state, so we're not going to get anywhere if we don't have both parties. But there's issues and elements of the problem and the solution that has champions all across our state government. So that's very good. And I think so we got to deliver, right? We were fortunate enough to get a big budget amendment, and this is one thing I'll say to folks: a budget amendment 24 that continued forward, and it was written that the dollars carried forward and automatically carried forward. And that's because a big component of it is capital, right? Capital projects. We're wanting to build more crisis sites, and capital projects don't get done in a fiscal year. But we also noted that we would need some amount of ongoing operational dollars. But that meant that that budget item doesn't go away, right? It gets smaller, and so we get down to the operational dollars and that get rid of the capital dollars. But that means it's going to continue to go. But it also means that my colleagues and I in our office have to continue to perform and make sure that the providers are building the building they said they were going to build and hiring the staff they said they were going to hire, and then serve the people they were going to serve. So that we got to keep the juice flowing. But what's next? I think we've talked some already about integrating 911, 988. Virginia is on is doing well there, but there's more work to do to make sure that those two systems work seamlessly and well. And I think another thing I was talking with the panelists yesterday, and I think is an important challenge to highlight is as we further mature our crisis sites, there's a challenge there that's different than 988 and mobile response services. And how do we establish sites that are secure, safe, bold enough to handle dangerous, high acuity situations, but don't slip into where we build a hospital, right? We don't want to recreate a hospital system, but we also need something that is secure enough to handle high acuity. And that's a really difficult sort of Goldilocks zone. And I think that's just it's a good challenge for us to make sure that we're supporting providers so that they can take the hardest cases and not create exclusionary criteria to move folks to higher levels of care.
Okay.
Wait,
I'm going to ask you.
Sorry, Ernie. I know you were, but I want to second something Leanne said too. We say off ramps a lot too, right? So if we get people into the crisis system, great. Then what, right? And I think that's a maturation of the crisis system, is to make sure we also have the on ramps, like no wrong door, but then can connect people out to the best next thing, so that we can all achieve the growth and change that we deserve on the other side of crisis moments.
Got it. Thank you. Thank you, my friend.
Yes, sir.
All right, let's shift our attention to Washington State, where we have Kimberly Hendrickson, again, program manager with the Washington Behavioral Health Crisis Outreach Response and Education. Hello, Kimberly. How you doing?
Hi, Ernie. Doing great. Thanks.
Good, good. All right, it's your turn. Are you ready? Let's bring it home. Question number one. There are a significant number of police, fire, and EMS agencies in Washington with specialized behavioral health response teams. So what did the alignment process teach you about the role of these teams and what they have in the crisis response system?
Yeah, thanks, Ernie. Before I tackle that, I want to just point out the difference between who I am as a speaker and other panelists, because I think it might help the discussion. BH Core is located in the School of Social Work at the University of Washington. We're a relatively new center that's devoted to helping crisis responders, regardless of what agency they operate from and the people that they serve. So BH Core has been really very focused, especially on crisis response from police, fire, and EMS since its inception. And because of that history of BH Core, when we were invited to join the Aligning Health and Safety process and we were able to form our first working group, we were very careful to have many representatives from the 911 system at the table, as well as from the behavioral health system and 988. And again, because of BH Core's mission to serve all crisis responders, regardless of what agency they come from, I think our Aligning Health and Safety process gave the state a really unique opportunity for practitioners from the behavioral health world to hear from first responders and vice versa. So our Aligning Health and Safety group, I think, spent a whole lot of very productive time talking about the things that you mentioned in your question, Ernie. Police co-response, but also fire and EMS co-response, mobile integrated health. We have had a renaissance in Washington State of behavioral health teams that are being run out of police, fire, and EMS agencies. And I think it might have been very enlightening and educational for many people in our Aligning Health and Safety group to understand the sheer volume of behavioral health calls that are still being responded to out of the 911 system, and the specialized teams that have developed and really matured in the past 10 years in Washington State to respond to those calls. So I appreciate the question because I love the focus on 988 and behavioral health, but in Washington State, I think we're quite unique in that the 911-based behavioral health response is so vibrant and so mature and is doing some really interesting things.
Yeah, you know, Kimberly, when we were in Utah, I don't know, about 6 months ago, and we were all convening together as states, you know, I remember your presentation specifically when you talked about, you know, integrating the fire department to respond to some of these behavioral health calls. And I thought it was an interesting approach because I'm familiar with these types of approaches. And I think one of the things you were starting to work towards was actually doing infield medication. And there was some question of like, well, who's responsible for that? Is it the medical director of the fire department that has to give the approval for that? Is it the direction of the local mental health authority or provider that has to do that? So you're working through these difficult areas to really navigate to bring the best quality services to the member in the member in the community that is just having a hard time even trying to find a ride to get to an appointment or right or to an intake or so, you know, I think you're really starting to work through some of these difficult issues and navigate some of the questions of what if. I think if a lot of these states can answer the what if questions that community members are asking, that's where we learn, right, to communicate together. And you're doing a fantastic job there. And I was really happy to see that type of approach. Um, Next question. The Washington group developed in crisis response. So what does this mean, and how does this relate to the functions of different crisis response teams?
Yeah, so this kind of goes back to something that Hallie brought up at the front of this seminar about the different role of the states versus all the decentralized stuff that is happening in crisis response. What our working group wanted to come up with was a couple of very simple statements that might be able to guide local level work with some general principles, but that could be worked out at the county and local level. And the neutrality principle is definitely one of those broader ideas. In its most simplest term, the neutrality principle is just the idea that whenever a call comes in for help in a crisis, doesn't matter whether it's to 911 or to 988, we need to match the response to the need. So I think, you know, for better or worse, that's not what happens in a lot of places. The response is just who's available, what's the contract, what does the union say? But that broader principle that we tried to work out in our Aligning Health and Safety group was, you know, what is the function of the team? What is the need of the caller? And how can we be working with our PSAPs and our 988 centers across the state to just understand that the highest ideal is to match the function to the need? Now, that's not going to be possible for a very long time because of workforce shortages that we've heard about, union contracts, existing relationships. We're not unrealistic in Washington, but if we can all commit to this higher principle that callers deserve their needs to be met in the most appropriate way, that can be something that we all work towards as a state.
Well, you know, you mentioned shortages, and you know, it sounds like you did some pretty good mapping there to understand what your gaps were. So my question for you, and then I want to get to really some themes that we've heard, and then get some questions from our attendees. But how did mapping help Washington understand gaps in crisis response capacity and regional variation?
Yeah, it's a work in progress. And again, I work for BH Core, which is a center at UW. We're doing the mapping exercise, and what we set out to do is to get responses from every crisis response team in Washington State, regardless of whether it's from a behavioral health agency, a city, a fire department, a police department, and overlay all of our crisis response teams on one map that can be, aggregated, disaggregated, but to finally give us in Washington a sense of, where are the services? Are we duplicating services? And most importantly, like, where are the service deserts? And, in an ideal state, we would have a wide variety of teams with different functions, MCOT, peers, EMS, police, but that's not always going to be the case. So with a map, if it's clear that in certain parts of our state, we have no crisis response teams, that's going to lead to some very interesting and important state level and local conversations about, what's possible to fill in the gaps and what's possible in areas that have many teams to make sure that the right team is responding, as I said before, to the need as it comes in. And Ernie, I just want to go back just for a second to your interest in the fire-based and the EMS-based teams, because I'm so proud of the work that's happening in Washington State, and I want folks on the call to hear it. There are many rural parts or frontier parts of the state that just simply, it's not realistic for an MCOT team to respond quickly to a call. So a lot of the responsibility is falling to volunteer firefighters, BLS units, ambulance units. I think part of our obligation as a state is to keep, moving the expectations up and understanding the importance of mobile crisis everywhere, while at the same time, through mapping, realizing that there are some parts of the state where the only crisis response is a volunteer firefighter, and then say, what can we do to support that firefighter? What kind of training can we send? What kind of telephonic support might there be? So we're shooting high and making the standards, but also acknowledging through mapping that some parts of the state are going to have different challenges, and we need to support what's there while building it up as well.
Yeah, no, I appreciate it. I can talk all day about how important it is to integrate fire and EMS into these programs. You mentioned mobile integrated health. I mean, that we started out here in San Antonio with mobile integrated health on hospice calls, and then it evolved into behavioral health calls. And before you know it, we were responding to the highest acuity, high utilizer calls. We were putting clinicians in cars with police officers, as well as paramedics, bringing medications out to the field. And what we saw was a reduction in the crisis calls and people getting into services and getting the help they need. So, Kimberly, I'm sure there's going to be questions coming for you as well in the chat. And I want to just take a moment now and reflect on the conversation that we all just had. And then I want to open it up for some questions here in a moment. But some of the themes that really I heard throughout this dialogue was getting the right response to crisis. I think that is paramount. If anybody's ever experienced a family crisis, I will say this: not everybody that calls 911 needs a 911 response. I think that's fair to say, right? You don't need a police officer showing up during a crisis call every single time. In some instances, yes, but not always. So getting that right response. Also, the community crisis response, it's a cross-agency effort. We've heard that today. It spans across many different agencies and stakeholders. Alignment between behavioral health, law enforcement, EMS, fire. And one thing we know for certain at this point, that legislature is essential. We can have all the good intentions in the world, but we truly do need the backing of policy and legislator to help move that needle. Also, policy wins. They're built on relationships and sustained engagement over time. These things take time. Sometimes you have to wait for seats to turn over for that to happen. But hopefully you hitch your wagon to a champion that's going to further this cause. And you see that done over time. And you just have to keep fighting the good fight. And every one of you on this call is a champion. The importance of focusing on larger goals instead of just particular reforms or legislative fixes. What's the why behind these efforts, the pros and the cons for passing state legislation and unintended consequences? I think we discussed that. The importance of a 911 system in crisis response and how it can be improved. And we heard it, right? We heard, how do we integrate 911 to 988 on the anniversary of 988? That's one of the ways that we can still provide crisis services without sending a law enforcement response, is using that, improving that system that's in place. Challenges of systems change that are highly decentralized crisis systems. And we know this. You use the word silos throughout this conversation. To me, that's another word for we're just decentralized. We're not all working together like like Kurt said, not even on the same page, because maybe that's not what we want, but on the same board. We're so decentralized, we're not even speaking the same language. States that ground policy in data and evidence are better positioned for durable change. We understand that data drives the dialogue in these conversations, and we need to be collecting good data and reporting out on this. And then I think the last thing I heard was that sustainability requires institutional and community champions, not just a single policy or grant cycle. And I mentioned that each of you are that community champion. I know that you'll say, no, it's an effort, it's a group effort, but it has to start with somebody. It's got to start with somebody that's an attendee on this call right now. It starts with you. You go back to your community and you start these conversations based on maybe some of the things you've heard today. So I do want to thank you for this dialogue, and I know we've got some questions, so I really just want to jump right into it. And Leanne or Kurt, I think either one of you can answer this, or both of you can answer this. But one of the questions that came in from Robert was, what innovative funding models or cross-agency cost-sharing strategies have you found effective to sustain and expand crisis response infrastructure in rural areas that lack the tax base of larger urban centers? Thank you, Robert.
Leanne, you want to go first?
Sure. So the question is really focused on rural areas and how can we expand and fund that when they don't have the same resources coming in as urban? Right. That is a really good question. And what we did in Utah is we removed the burden. We have legislative funding that we are able to give to them for MCOT, and I'm speaking for MCOT. And we have been able to do some receiving centers. And what we've done is eliminate any match that they would have to do to make sure that they can operate these teams, not put up any barriers. And then we're also trying to, and we've advocated for, the Medicaid bundled rate and implemented that, as well as looking at private insurance so they can find ways to reimburse as well. But it is a challenge, and those are some of the things Utah has done to try to compensate for that.
Yeah, and I'll just echo the challenge part of it, I think. And so I don't know that we have perfected an answer to it, but some of the same themes that providers aren't going to turn a good profit in rural areas, right? And I think the state needs to recognize that and accept that. And so, I mentioned mission and selling, sort of a big part of my role, I think, is making sure that we stay on the same page. And one of the components of crisis now, I think, for it to be successful is for it to be a statewide system, right? Because people don't stay in one space, they move around. And so it's important for our leaders in urban areas to recognize the value of the services in the rural areas and how it impacts them. And so we do have, I think the other critical component for us is having a regional system. So Virginia's broken into 5 regions, and our mobile crisis response and 988 contact centers are through our regional hub. So our state general funds go to them. So our region 3, that's the Southern and Southwest Virginia, gets funds and is expected to hire staff and deliver mobile crisis, whether they get Medicaid or private insurance reimbursement or not. And so we ensure that they get sufficient general funds to at least meet minimum KPIs, right? And they do that. And there are a few fee-for-service private providers in the rural areas. There's more in the urban areas because there's more opportunity. But so I think both of those things, like one, just an acceptance that we're going to have to put more general funds into rural areas, and it's going to fall more to the backs of our publicly funded providers, and just accepting that that's what's needed to have a successful statewide system. But then also supporting, again, infrastructure, like a regional system that can meet the needs of the area and pull in private providers where it works well and create the relationships and contracts to be successful. But check in 10 years and find out if we've been able to sustain, right? Like
I got faith in you, my friend. It'll be sooner than. But Cart, let me ask you. Sticking with you, Devonte had a question, specifically while you were speaking, and he said, "Is the community supports and fee for service models similar to the claim initiative in California?"
I saw that question and wasn't familiar, so Googled
Okay.
that initiative while others were speaking, and I don't think so. I mean, I have about 10 minutes of familiarity with the claim system, but no, I don't believe so. What we've set up is mobile crisis response. We've defined as a specific service. It's a voluntary service. It can, like Leanne's system, it can dispatch it from our 988 contact centers. But it's a defined Medicaid reimbursable service up to 4 hours, was 8. We're transitioning it to 4 hours, up to 4 hours, 15-minute increments, all that kind of stuff. So it's got its own billable code. So it is a distinct standalone service, not wrapped into something broader, which is what the claim, if we're pronouncing that right, looks like.
I'm suspecting that it's a reference to CalAIM, which is California's Medicaid initiative. And so I'm curious maybe generally how different states are using Medicaid to pay for crisis services. That might generalize the question.
Yeah. So, well, then in that instance, yes. So mobile crisis, we also have a sort of, we'll call it a gap service called community-based stabilization that may be sunset soon, but then our 23-hour and residential crisis stabilization units, those are all Medicaid reimbursable services, which I think is a strength for us, that we're able to get good reimbursement. Providers will say the rates are good, but they're not sufficient. And again, time will tell, right? So we're just trying to make sure that we have sufficient general funds and Medicaid reimbursement. And that's, sorry, last thing, and then I'll stop on here. But that's also been a challenge for us to go back to that infrastructure point. Like, we create the system so that we get the right amount of service provision, right? If it's fee for service, you can end up having sort of overutilization, which is good if people get a service, but can also strain the system if it's more than it's indicated. If we start to fill gaps with mobile crisis or 23-hour and use it for other needs, it can strain. But so it's good that we've opened them up and provided quality reimbursement, but that also means we got to monitor the system functioning as well in a different way.
All right, thank you, Cart. Tiffany. I don't know if this question is specifically for you, but I like this question for you. Yeah, so let's just play with it and see what happens. So Gavin sent a question and it says, how can you advance this work with state legislator that does not feature bipartisan work on most issues, including crisis response initiatives? Asking from Tennessee. Thank you.
So I think I understand where we're going here. So for us, it was really, and I think I sort of led with this. We were all seeing the need. So law enforcement was saying the need and saying, this is a safety issue for us. This is a retention issue for us. You're making our jobs harder by making us mental health professionals, or demanding that we become mental health professionals. And so they were asking for it. And so that might be persuasive to one side of the aisle. But then we also had community members and community-based organizations that were saying the exact same thing. So I think it was the unity in message, and then the willingness to sort of work together on solution. But I think the need was coming from all sides of the aisle. I think the other thing that we have tried to do in New Jersey is, to the extent that we can, lower the building of infrastructure costs. So, for instance, I know that there were many municipalities that had embedded social workers.
Mm-hmm.
That involves a law enforcement agency paying for the staff of a person, and we know that's really expensive, especially when you start adding all of the fringe benefits and all of those things. Or they were building an infrastructure that then it was an organization and they needed a building and they needed staff and they needed all those things. We were leveraging existing resources. So we were also keeping costs down by still giving the resource. And so I think we've had bipartisan support in the need. Now, we might not have bipartisan support in like the how, but we definitely have it in the need. And I think how we so far have managed the bipartisan support in the how is by talking to each other in the background. I say all that, but right now, and it could all change. We have a Democrat governor and a Democrat that's in both of the houses. So we currently have not tested this in a world where there's a huge division. So, but we are seeing bipartisan support, even though we're sort of lopsided one way right now. I think it's really because all of those stakeholders, from law enforcement to community to healthcare, are all on the same page of the need for an answer and the willingness to work for it.
Okay, thank you.
Ernie, could I add on to Tiffany's answer?
Sure.
Because I think this is a really important question. And we also have some really direct experience about this in Washington State. I think when our really big push for 988 rollout happened in 2021, there was perhaps a unusually strong emphasis on police doing things wrong. So let's get things out of the 911 system and into 988. A lot of the framing in Washington State was police have failed, so let's use 988 as an alternative police so we can do it better. And as we've worked through integration processes and more mature conversations in Washington, of course, we've come to the obvious conclusion that there has to be integration. Different calls require different responses, different sets of expertise. There is no either or. 911 and 988 has to be an integrated system that works together. But boy, did we waste time using language that suggested the either or that 988 was a replacement or should be a replacement for 911. So for listeners on this call that are interested in being more bipartisan about this issue, I think the sooner we can leave our negative language about our conventional first responders and understand that we're all crisis responders working in a system trying to do the same thing and help the same people, the quicker we will get to that bipartisan place.
Thank you, Kimberly. I appreciate you adding that. Before I get ready to hand it back to Ms. Hallie, I just want to take the time to thank, Tiffany, Leanne, Kimberly, Kurt, for your participation, not only today, but throughout, the 2 years that, we've worked together to try to learn about your crisis systems, to help, move the needle either through recommendations or mapping, infrastructure. It has been an honor. It has been a pleasure to work with each of you in your states. I'm a better person because I know you today, and you have continued to inspire me, to push hard in this area and continue to help other states. And my hope is that this conversation that we had today will yield more interest in this area, and we'll continue to have individuals reach out to us to inquire about how can CSG or Pew help, fund or help, with crisis system mapping and with technical assistance. Well, we're here for you. And I want to thank you again for your time. You've been phenomenal guest today. The information you dropped was liquid gold. We truly appreciate it. And with that, Ms. Hallie, I'll hand it back to you.
Thank you so much, Ernie. I just was remarking that the folks who we have on the call are a really neat cross-section of who's doing this work, right? We have retired law enforcement, we have health, we have universities, we have Attorney General's office, community members, foundations. It is quite a coalition of folks who are all working together in very different states, and from wherever they sit to help keep our community safe, healthy, get the right response to crisis. As you've heard, there are an enormous plethora of crisis response policies, strategies, resources that are all growing up around the country. And one part of our project was to try to synthesize this and save folks the internet search so that you don't have to be looking for a triage protocol if someone's already put one together. And so what I'd like to do is share the results of that. We're launching today with you all, brand new webpage, but also make an invitation for those who are in the audience. If you have resources that you'd like to see featured, really what we're trying to do is create a place where the field can learn from each other. So I'm going to take the extraordinary risk of trying to do something fancy on my computer and share my screen. So this is the web page I hope y'all are seeing for aligning health and safety. This is through the Justice Center's website. And if you come to aligning health and safety, you see we have the state policy tool. And we've had the state policy tool for a while. The idea is, again, to save state leaders and local leaders who are working with them from reinventing the wheel and distill some of what we've learned from our decades of experience working with states at this intersection of justice, health, and housing. So we have had up till now 3 foundation models. And today we're launching this brand new module focused on crisis response coordination. And those 6 key areas that we included as at the poll at the top of the session are the policy goals that you see here within the module. And since our group today was interested in funding strategies, I'm going to show you what happens. You can click on the policy goal. It prompts you with a question to think about for your group. Click on the question and you get both the rationale for why this is something that we focused on, some tips for if you're in a state task force or you're in a role where you're being asked to think about how to put together funding for crisis response. We have ways to do it from around the country. Things to consider as you're doing it. This is sort of the advice portion. Then we have how different examples from different states, and we really try to include very different states, whether it's geography, politics, resources, to show how wherever you are, there's someone like you who has tried to do this and succeeded. You'll see our friends from Virginia, Washington, New Jersey, and Utah featured throughout, but also other states. And then some of the national resources or examples from around the country. The web page has some cool functionality where you're able to like clip things and put them in your own folder so you don't have to have many tabs open, as some of us might at the end of the day doing research. But the idea is to help make it easy for everyone in the field to identify examples of what's going on around the country. And we hope that facilitates the work that you all are doing in your own states. Huge thanks both to the folks who are on the phone, to our partners at Pew, as well as to colleagues at the National Association of State Mental Health Program Directors and the National Conference of State Legislatures who've reviewed this and helped us make sure that we had their favorite examples as well. So this is our brand new Aligning Health and Safety Policy module. Felicia was good enough to put the link in the chat. We hope that it's useful for you all. Let us know if you have any feedback or if there are additional examples that we should be sharing. Ernie said it better than I could, he usually does, thanking our panelists for all of the work that they're doing. Thank you to Connie, Hillary, and others at the Pew team for your partnership. And really, this continues to go forward. While this is the end of our Pew-funded project, this is work that CSG continues to do. We're operating a TA center for the state of Pennsylvania focused on CIT and crisis response. And we're eager to work with you if there are ways that we can support your work. Thank you all for your time together. Thank you to all of our speakers and the team behind the scenes, and have a great rest of your day.
Thank you.